Good morning to all. So today we will start with the quote, habit is the intersection of knowledge, what to do, skill, how to do, and desire, want to do, what you want to do. So today we will be covering oral habits and these are the contents. So oral habits has been the object of discussion, and habit is being formed with the help of resistance to any change. When we do not want to change, it becomes our habit. And often because of the harmful habits of the children, parents feel guilty of their maturing practices and they seek remedy to intercept it. So these are certain definitions which are given by different author, but the most accepted is of Boucher's, which is given in 1963, a tendency towards an act or an act that has become repetitive performance, relatively fixed, consistent, easy to perform and almost automatic. So these are the other definitions. So how can you classify the oral habits? We can classify them as obsessive deep-rooted habits which have intentional or meaningful, or maybe they are self-inflicting. Non-obsessive habits are unintentional, empty or functional habits. So how to classify it? James in 1923 have classified them as useful or harmful habits. Kingsley has given as functional, muscular and combined habits. Then Morris and Bohanna in 1969 have given pressure habits, non-pressure habits or biting habits. Klein in 1971 has categorized them as empty habits or meaningful habits. Then Finn has given it as compulsive habits or non-compulsive habits. Then habits can also be classified based on whether they are physiological or pathological. So we will today study the thumb sucking habit, or which is also known as digit sucking or finger sucking. So O'Brien in 1996 has given that one is the nutritive sucking habit, in which the bottle child is fed with the bottle, and other is the non-nutritive sucking habit, which is thumb sucking. So repeated or forceful sucking of thumb with associated strong buccal and lip contraction. The definition is given by Moyers, which is the most accepted. How do we classify it? As normal thumb sucking till 3 years of age or 1 to 2 years of life, which disappears after maturation, and abnormal thumb sucking is which persists beyond the preschool, means at the age of 4 or 5. It causes malocclusion. Then psychological, which have deep-rooted emotional factor involved, associated with insecurities, neglect, loneliness, or habitual with no psychological bearing. Child performs an act out of an habit. So Sattelny in 1973 has given 4 types of thumb sucking. Type A, which is seen in 50% of children, type B in 13 to 20, type C in 18% and type D in 6% of children. The clinical aspect which has been defined by Moyers is phase 1, phase 2 and phase 3. In phase 1 it is normal subclinical significant sucking. In phase 2 it changes to clinical significant sucking. In phase 3 is intractable sucking. What are the etiological theories? We can classify them as classical Freudian theory. Like the child is already having inherent psychosexual drive in the oral phase, where the center of attraction is the oral cavity, and a tendency to take everything to the oral cavity because of deprivation, insecurities, anxieties, etc. So then the other theory is given by Sears and Weiss, which is oral drive theory. It says that how long a child continues to feed by sucking strengthen its oral drive. So it is strengthened by prolongation of nursing, as given by Sears and Weiss. Then third is the learning theory, which is given by Davidson in 1967, say that there is no underlying cause. Digit sucking is a habit, simple learned response. It is also given by Benjamin in 1962. So Benjamin's theory is of rooting reflex. Rooting reflex is common to all mammalians and it occurs seen mostly during first 3 months of life, but if it persists, it becomes an abnormal habit. Then soughing reflex, as explained by Ergel, is babies restrict from feeding due to disease or other factor, resist or irritable, deprivation, and additional gratification if they want. So what are the clinical findings? Position and direction of digit associated with orofacial muscular contraction, position of mandible, intensity, duration and frequency. So extraoral findings are dishpan type of thumb is there. If we keep our thumb at long hours in our mouth, then the digits becomes like this. And Vogel says it is the eczema of digits due to dryness and moisture that occurs. Lips become hypotonic, lower lip becomes hypertonic, increased lip up incompetence and increased lower lip functions. Facial form analysis shows maxillary protrusion, mandibular retrusion, high mandibular plane angle, then convex profile and mentalis muscle contraction. Intraoral examination shows what are the effects on maxilla. Labially tipped maxillary incisors, contracture of cheek muscles, posterior teeth caused bite, hypotonic upper lip and interior open bite along with increased overjet. Then buccal walls, posterior crossbite is seen because buccal wall contraction is there. It creates negative pressure within the mouth. No compensatory forces are occurring from the tongue, which leads to narrowing of the maxillary arch, leading to increased posterior crossbite in these children with the habits. Effect on inter-arch relationship, interior open bite is there and increased overjet is there. So much teeth are ahead of the lower teeth. Then effects on lip and tongue position is lower, tongue thrust swallow occurs in order to maintain the interior seal. So diagnosis is done by the history, by active performance and information from mother, which we get, emotional status of the child, whether it feels neglected, from anxiety, something like that. It is normal. So these are some of the questions which we should ask. What is the probable cause? It is essential to intervene in this time, etc. So the treatment, according to the steward, they said it is psychological, reminder therapy and mechanotherapy. So management can be the existing potential malocclusion should be resolved, emotional status should be corrected according to the age of the patient. Behavioral procedures such as positive and negative reinforcement when sucking, if interrupted, is effective in stopping the thumb sucking habit, which is given by B.F. Skinner's operant's conditioning theory. Then Dunlop beta hypothesis also suggests that if we says the child to look into the mirror, we can lead to forced purposeful repetition, then the abandonment of this habit is seen. Then the reward therapy, which is also known as contingency contracting. Then 3 alarm system is also there, that wrap the digit which he sucks with the coarse adhesive tapes, elbow firmly wrapped, and the 3rd alarm is the bandage is tightened. Mechanical restraints like thumb guard, nail polish, parent counseling. Chemical treatment like quinine, asafoetida, pepper, castor oil, famide can be then. Then comes at the last mechanotherapy, which is we can put some of the appliances like palatal grip appliance, hay rake appliance, bluegrass appliance. So these are some of the appliances which we can give. So this is all for today. Thank you.